Before comparing these approaches, we need to clear up the family tree. What came first and what came later? Now, ACT and DBT are what we call third wave therapies. Now, third wave, that means there was two waves before it. CBT is a second wave approach, also known as cognitive therapy, that was developed by Aaron Beck. And it's also commonly used for an umbrella term that has a much larger family of therapeutic approaches, including ACT and DBT. Now, first wave was called the behavior therapies. And you could think of that like B.F. Skinner and others that were more concerned with the learning conditions and observable behavior, what people do and how to influence that behavior. ACT and DBT are often called third wave behavioral therapies because they place a greater emphasis on processes such as mindfulness, acceptance, context, and the function of behavior. They did not simply throw out everything that came before. They are building on their predecessors, and they remain part of a broader behavioral tradition that started with the first wave. All three approaches are collaborative, and all three try to understand why a person may be stuck. And all three ask people to do something outside of therapy to improve their daily lives. The difference is mainly one of emphasis. What is the therapist paying attention to? How is the problem being maintained? And which intervention makes sense at this point in treatment? Now, to see that difference, let's run one situation through all three approaches. Imagine that you send an important message to someone and do not receive a response. You immediately think, I must have done something wrong. They're upset with me. You feel anxious. You reread your message 10 times to make sure it's correct. You begin replaying your last conversation, searching for the mistake. What did I do that was wrong? Through a traditional CBT lens, the therapist may slow down the sequence and separate the observable events from your interpretation. The observable event is that you sent a message and have not received a reply. They're upset with me is one possible interpretation of that event. You and the therapist might examine the evidence supporting that interpretation, look for information that does not fit it, and consider other explanations. Maybe the person's busy. Maybe their phone is off. Maybe they saw the message and forgot to respond. You simply do not have enough information yet. The goal is not forced positive thinking. You are not replacing "they hate me" with "everyone loves me." The goal is to develop an interpretation that is more balanced and better supported by available evidence. You might then test that prediction through behavior. So instead of sending 5 more messages or avoiding the person, you wait for an agreed amount of time and follow up directly. That gives us a useful CBT question. What am I telling myself about this situation, and what happens if I test that interpretation? Now let's view the same situation through an acceptance and commitment therapy lens, or pronounced ACT. Now, ACT may spend less time determining whether they're upset with me is true or false. Instead, the therapist becomes interested in what happens when you get hooked by that thought. Maybe the thought begins directing your behavior. You keep checking your phone. You cancel your plans. You send another message and another message, even though experience tells you that doing so creates more tension. ACT calls this cognitive fusion, becoming so entangled with a thought that it dominates what you do next. A simple diffusion exercise might involve changing "they're upset with me" to "I'm noticing that I'm having the thought that they're upset with me." That sentence does not prove the thought is wrong. It also does not make the anxiety disappear. It creates a little space between you and the thought, that the thought is no longer the only influence on your behavior. ACT's central aim is psychological flexibility, contacting the present moment and choosing behavior that serves your values, even when difficult thoughts and emotions are present. In plain language, ACT helps people open up and pay attention, and then do what matters. In our example, you might identify values such as respect, honesty, patience, or being present with your family. You could allow the anxiety to be there while putting down your phone and returning to the activity in front of you instead of obsessing about the email that has not been responded to. Now, that gives us the ACT question. Am I hooked by this thought? And what would I do next if my values were leading? Now, let's look at this through the DBT lens. DBT was developed by Marsha Linehan for people experiencing chronic suicidal behavior and severe emotional dysregulation, particularly people diagnosed with borderline personality disorder. It has since been adapted and studied with other populations and concerns. Now, the word in dialectical behavioral therapy refers to bringing apparent opposing truths together. A DBT therapist may communicate, your reactions make sense given your history and what you were feeling, and this behavior is creating serious problems that we need to change. Now, both sides matter. Acceptance without change can leave someone stuck. Pressure to change without validation can feel shaming and may damage the therapeutic relationship. Now imagine that the unanswered message leads to a much more intense sequence. The person feels abandoned, sends several angry messages, threatens to end the relationship, or experiences an urge to harm themselves. A DBT therapist might conduct a behavioral chain analysis to help show how this is happening. Now, what vulnerability factors were already present? Was the person exhausted, hungry, physically ill, maybe using substances or carrying stress from an earlier conflict? What exactly was the prompting event? What led to that behavior? What thoughts, physical sensations, emotions, urges, and actions then followed? What was the immediate consequence? And then what happened later? You keep asking, and pretty soon you have 10 or 15 different parts of what was happening. Once the chain is visible, the therapist and client identify specific links where another response could be inserted. That response might involve mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness, the 4 primary DBT skill modules. Now, the person might use a crisis survival skill before responding. Maybe they check whether the intensity of the emotion fits the facts, or use an interpersonal skill to ask for reassurance without attacking the other person. That gives us the DBT question. What chain brought me to this behavior? And which skill belongs at which link? Now, quick break. If you would like a worksheet and a handout and also clinical resources that I create for this channel, you can find them at shaunhardie.com/resources. And I actually made a worksheet just for this video. So the link is in the description and pinned in the comments below. Now, which approach has the best research and which should you use or want in therapy? Well, there's no universal ranking of which is best, and it's each have a different focus that they use. The research for CBT and ACT and DBT is robust all around, and both are considered gold standard treatments for various mental health and medical disorders. ACT has been shown, for example, to work really well with depression, anxiety, and chronic pain, while DBT shows really good evidence for helping with borderline personality disorder, bipolar, self-harm, suicidal behaviors, and severe emotional dysregulation. And CBT has been shown to work really well with OCD and other specific thought patterns and mental health issues. Comparing the 3 is also complicated because CBT is a broad family of treatments, while ACT and DBT are more specific models. That's why going to a CBT therapist is really general, and you're not really sure what kind of CBT therapy that they're using, while ACT and DBT have more specific models that the therapist is going to be pulling from. So that brings us to how a therapist actually chooses. Well, first, the therapist identifies the primary treatment target. What is the goal here? Is the immediate priority reducing a safety risk, interrupting avoidance, examining an unsupported belief, improving behavioral control, building a life organized around meaningful values. Where's the client at and where are they hoping to go? If it's more skills, I might lean towards DBT or even CBT. CBT is really good for analyzing specific beliefs and thoughts, while ACT is really good at getting the client unstuck and moving toward a life that matters. Second, the therapist might consider the process or function that's maintaining the problem. So is it a belief that is leading to the behavior, or is it experiential avoidance that is creating this stuckness and struggle? Is it suicidal ideation, and are there safety issues here that are maintaining the problem? So what's the function of it? Third, the therapist considers the client's preference and where they're at. Clients, they have a lot to say about what they feel would be most helpful. And sometimes they have had experiences with maybe CBT or ACT or DBT that they say it was not for them. And so that's something that I would maybe field and just say, if it does come up, pivot to something that might be more useful for them. Fourth, finally, the therapist must consider their own competence and their scope of practice. If you have not done trainings for DBT, ACT, or CBT, then just downloading a worksheet and using it in therapy, it might be ill-advised. You need to be trained and comfortable with the therapy that you're using. Now, it's okay to try things out in therapy and pick from different modalities, but make sure that you're understanding the material as you go to use that. And especially before you call yourself an ACT therapist, a CBT therapist, or a DBT therapist. Integration can be effective. And I sometimes will mention two approaches in my intake that would fit this particular client instead of boring them with all the trainings that I've done and all the things I can do. I mentioned two that would be helpful to them. So maybe that's DBT, or maybe that's ACT, maybe that's CBT, or I might throw another one in like motivational interviewing or Gottman method. It just depends on what issue that they're having and what I think would be helpful for them. So here's the takeaway. CBT may ask, what am I telling myself and what happens if I test it? ACT may ask, am I hooked and what would I do if my values were leading? DBT may ask, what chain brought me here and which skill belongs at which link? Those three questions help us see the different parts of the same human problem. So the question is not necessarily which therapy is best, although I prefer ACT in many cases. That's why I do this channel. But the better question is, what does this person need next? And which evidence-based process is most likely to help them? Do they need a belief to be challenged to see the interpretations more accurately? Or do they need help getting unstuck and living towards what matters? Or is there safety issues and skill deficiencies that you could work on together that could help improve their life and their relationships? Thank you for watching this video, and I hope this has given you a better understanding of the differences and similarities between CBT, ACT, and DBT. See you in the next video.